Derek Scioli, our CEO, will give an introduction to the webinar and introduce Dr. Biake.
Good morning, everyone. It's my pleasure to be with you for today's webinar on the HN-Salve trial. Globally, over 700,000 head and neck cancers are reported every year. And in fact, this may just be the tip of the iceberg in terms of the true burden, as incidence rates are likely grossly underreported in emerging markets. For example, in India, it's estimated that 30% of the cancer burden are head and neck cancers. Too often, especially within poor demographics, these cancers present as advanced, and throughout the world, recurrence rates unfortunately remain quite high. A few years ago, we kicked off a research initiative called Treat the Untreatable, where we challenged our IORT user base to present promising research opportunities for the most difficult cases they were dealing with, for patients who don't have good options today, and where increased local control can mean a meaningful impact in patient outcomes. We were especially interested not just in IORT, but really in combination therapies that leveraged a full multidisciplinary approach using the latest scientific advancements. Dr. Biake and the team at Ohio State University presented the HN-Salve trial combining immunotherapy and IORT as part of that initiative, and we're delighted to see that this innovative approach evolved from early concept to now enrolling patients in the very near future. I trust that you'll find this session both interesting and educational, and we all look forward to getting more updates on the progress of this new research and trial in the future from Dr. Biake and the rest of the OSU team. So without further ado, I'll introduce Dr. Dukajin Biake. He is an associate professor and associate director of clinical operations, as well as the director of head and neck and skull-based division within the radiation oncology department at the Ohio State University Comprehensive Cancer Center. Dr. Biake earned his bachelor's and master's in molecular biophysics and biochemistry from Wesleyan University, and a PhD in biochemistry and doctorate in medicine from Albert Einstein College of Medicine. His research interests are clinical and translational in nature, with a focus to tailor cancer treatments to patients based on their molecular profiles of treatment resistance. And he's conducting new research that leads to new clinical trials, as we'll get to hear today on the HN-Salve trial. So Dr. Biake, please take it away.
I would like to thank INTROP and the organizing committee for giving me the opportunity today to talk about HN-Salve trial, where we're combining immunotherapy with salvage surgery and IORT for treatment of persistent recurrent head and neck cancers. My name is Dukajin Biake. Folks call me Duke, and I am the radiation oncology director of head and neck and skull base. So in terms of background, the standard of care for local or regionally recurrent head and neck cancer is surgical resection with adjuvant therapy. Local control after surgery alone is unacceptably low, and post-op chemoradiation has been shown to improve both local control and progression-free survival. Local failure remains the primary site of recurrence, and overall prognosis is poor. And IORT may play a role in improving both local control and decreasing toxicity for these patients. Our standard phase 3 trial from France showed 130 previously radiated patients with recurrent head and neck cancer. They were randomized to surgery followed by either observation or chemoradiation. So radiation was external beam to 60 gray with concurrent 5-FU and hydroxyurea. It is important to note here that this randomization actually occurred prior to the surgery. So the clinical trialists were not using pathologic information in order to make these randomizations. They were just making the randomization, and regardless of what the pathology showed, they would follow that specific randomization. The results were fantastic in terms of local control improvements, disease-free survival improvements. However, there was no overall survival improvement. And some folks think that that may be because of that initial randomization that we just discussed. The toxicity, however, was significant both at 1 and 2 years, with 26 patients out of the 130 having RTOG grade 3 or higher toxicities, and 39 patients at 2 years with grade 3 or higher RTOG toxicities, which included pharyngeal stenosis, the osteoarthritis, trismus, and so forth. So the purpose of our study initially was to conduct a retrospective review of our clinical outcomes using IORT for recurrent head and neck cancer, compare our outcomes to historical controls, and determine if surgical margin status has a significant impact on local regional control, progression-free survival, as well as overall survival. So at Ohio State, we've been doing intraoperative radiation therapy for over 30 years. In the salvage setting, we've started more in the early 2000s, and so we reviewed from 2004 to 2015 the number of salvage cases at Ohio State. We had a total of 99 IORT cases, but of those 61 were salvage, and of the 61, 45 had squam and 17 were non-squams. And within the squams, we had 18 with positive margins and 21 with negative margins. Patient characteristics revealed about 90% of these patients had recurrences, whereas 10% had persistent disease. The male to female ratio was 64 to 36%. And the primary sites of disease were oropharynx, oral cavity, sinonasal, and larynx, with salivary, unknown primary skin, hypopharynx, and neck disease as well in the unknown primary setting. IORT primary site was 67% of the time, whereas the neck recurrence was 33% of the time, and histology was predominantly squamous cell. The margins were positive in 46% of patients and negative in 44% of patients. Perineural invasion was looked at, as was lymphovascular invasion. Prior radiation therapy, 44 of these patients had surgery previously. External beam, one course was in 54 patients, two courses in 2 patients, and IORT and external beam in a couple of patients as well. The median dose was 12.5 gray, which ranged from 10 to 17.5, but you can see that most of these doses were in the 10 to 15 range, and the predominant energy was 6 MeV, and the predominant bevel diameter was between 5 and 6 cm. It's important to note at this point, and it's important to understand that the namesake of the Cancer Center at Ohio State, the James Cancer Center, is Arthur James. Dr. Arthur James was an ENT doctor, and so we have a long-standing tradition of being, of excelling in the care of head and neck patients, of head and neck cancer patients, especially. And because of this, we have about a 3-hour radius in which folks from multiple neighboring states and all within Ohio come to Ohio State for head and neck cancers. And what happens at times, patients will have their surgery, will have intraoperative radiation, and then because of distance, because of multiple factors, aren't able to come back for external beam radiation therapy. And this is what occurred in our cohort as well. About 2/3 of the patients only had surgery in IORT, so about 38% had surgery, IORT, and external beam, and about 15% had surgery, IORT, external beam, and chemotherapy. And despite this, you see some of our results, which are comparable to the phase 3 French trial that I described in the beginning. So 1-year local control is approximately 60%. With 1-year overall survival also at 60%, and 2-year overall survival at 40 or 42%. If you had squam histology, you did worse than if you didn't. That was significant. Positive margins were worse than negative margins, which are things that we expect. And what was intriguing is to note that the receiving post-operative external beam radiation therapy versus not receiving post-op external beam radiation therapy didn't seem to play out in terms of local control. This is now depicted in a graphical with a 1-year local control at 60% or 59%, 1-year disease-free survival at 39%, and 1-year overall survival at 62%, with the 2-year overall survival at 42%. Looking at margins, in terms of local regional control, margins didn't play very much of a role, whereas in overall survival it did, and in disease-free survival, there seemed to be a trend at the very least. So margins are important in this, and we know that, and it's reassuring that this data revealed the same thing. In terms of toxicity, we had 1 grade 5 toxicity, which was a carotid blowout. This occurred 18 days after surgery and was within the IORT treatment field. However, the patient had a split thickness skin graft placed over the carotid at the time of surgery, and we think that also had something to do with the unfortunate situation here. The other significant toxicities were osteoarthritis necrosis in 2 patients, wound dehiscence in 1, percutaneous fistula in 1, and tracheoesophageal fistula in another. And these were surgically managed well. So in conclusion, in a population of previously radiated recurrent head and neck cancer patients, IORT achieved 1 and 2 year overall survival rates comparable to the French trial, despite only approximately 40% receiving postoperative RT and 15% receiving postoperative chemotherapy and radiation therapy concurrently. So advantages of IRT may include decreased toxicities and decreased duration of post-treatment if we do these historical comparisons. This paper was published, and a lot of credit goes to Dr. Wald and Dr. Kusula, as well as the rest of the team who's depicted here. So in terms of future directions, we want to take this information but pool it with folks throughout the country and internationally that have head and neck data, so that we can increase our numbers and show that this is a viable technique and something that should be offered for our patients. Prospective protocol, we have a prospective protocol looking at the safety and efficacy of salvage surgery and IORT with and followed by immune therapy. So the hypothesis here is that adding IO and pre-op RT to IORT will improve upon our local control and progression-free survival outcomes. This is the HN Salve trial that is currently going through the IRB and should open in the next few weeks to a month or so. So there's quite a bit of data revealing the head and neck squamous cell carcinoma display, that head and neck squamous cell carcinomas display an enriched immune landscape with key immunological implications. There's differences between HPV positive and negatives, and the hypothesis is, can we provide new antigens with radiation therapy to quote unquote jumpstart the immune system in the recurrent persistent head and neck cancer population? So radiation therapy may increase the capability of the immune system to exert its function through neoantigens, through mutagenic activity of radiation, to boost antigen presentation, enhance killing by CD8 T cells, and so forth. We have looked at our patients who have been on the recurrent metastatic setting, and together with Dr. Bonomi and team, we've worked towards looking at these folks and seeing if we can come up with an algorithm and a nomogram, which we did, that looked at blood draws, very simple blood draws that can be done anywhere in the world, honestly, and a simple immunohistochemistry stain for P16. By looking at platelets, neutrophils, lymphocytes, albumin, hemoglobin, LDH, and P16 status, we've developed a point score, which helps us look at median survival time in months, 2-year survival probability, and 1-year survival probability. Another way to depict this is within that nomogram. If you have 0 to 100 points, your overall survival is close to 24 months, whereas if you have 101 to 150 points, you're closer more to 18 months or so, and versus 151 to 300 points where you drop to about 3 months or so. This has now been internally validated. We had 121 patients here, and now we have 201 patients also showing this and updating our numbers from 2018 to 2020, and looking specifically, so from 2016 to 2020, immunotherapy has evolved from last line to more first or second line treatments, and that paper is going to be submitted in the next couple of weeks. But we're very excited about this, and we're starting to see differences, as well as out of those 200 patients, we have whole exome sequencing and RNA-seq data from about a third of them, and we're starting to see molecular signatures that may also help us in understanding who's going to benefit most from immunotherapy. So we're still in the beginning of this, and we're hoping that HN Salve trial will also help us, because the translational component of that trial is as important as the clinical component. So folks understand that a lot of work done from Dr. Fermenti and Dr. Di Maria's laboratory have revealed that different doses of radiation may induce or may suppress the immune system. So doses of A grade times 3 may induce the immune system through the C-gas sting pathway versus inhibiting it through the Trex pathway. And what we're proposing in our trial, which is finally, after quite a bit of delays due to the pandemic and so forth, it looks like we'll be open in the next few weeks. We're looking at recurrent persistent head and neck squamous cell carcinomas, where we'll have tissue biopsies. We'll maintain that tissue. We'll look at specific imaging so that we can look at radiomics as well, but all standard of care. And then we'll provide immunotherapy. We'll have blood, urine, and tissue as described. And then we'll provide some preoperative radiation, either 2 grade times 2, because this is a fractionation in radiation oncology that we use pretty frequently, versus A grade times 2, as I showed previously in the preclinical model, that this may be something that quote unquote awakens the immune system. Then the patient will go through surgery, an intra-op dose of 10 to 15 gray. We will then have that sample of tissue, blood, and urine, which we will store, and we'll provide immunotherapy for up to a year and follow closely until progression. The primary endpoints here are toxicity and feasibility. There'll be 15 patients per each arm, and the secondary endpoints will be 6-month local control, disease-free survival, and overall survival. And the clinical and molecular translational analysis will be key here, because we'll have tissue prior to immunotherapy, tissue after immunotherapy, tissue prior to immunotherapy to compare within one patient, and tissue after 2 grade times 2 and immunotherapy, and then tissue A grade times 2 and immunotherapy. So it'll be a very unique opportunity to really learn quite a bit about how immunotherapy is being affected, how these doses are affecting immunotherapy, and so forth. And the goal is to eventually, with this trial being complete, to see if we can open a phase 2 randomized trial where perhaps one of these two, either 2 grade times 2 or A grade times 2, becomes the quote-unquote winner, if you will, and we move forward with a phase 2 multi-institutional trial. Obviously, we're also working quite hard and have the flash intra-op machine, and so those are things that we're considering as well as we start to work towards preclinical to higher vertebra and eventually to human trials as well. So with that, I want to acknowledge Dr. Arno Chakravarty, my chair at the Ohio State University's Radiation Oncology Department, Dr. Gusula, who's been doing this for a very long time, Dr. Gomez, Dr. Wald, who did a lot of the work for the initial manuscript, Dr. Mladkova, who's worked very hard towards the implementation of this protocol, Georgios Leliotis, who has been a pleasure to work with as well as Dr. Mladkova, and Dr. Bonomi, who's our head of medical oncology, and he and I have done a lot of the work in the immunotherapy. Dr. Rocco, who's a mentor and a lead of the head and neck disease line at Ohio State. Dr. Old, Dr. Ozer. Dr. Old is the lead of the service line, but also the lead of the head and neck cancer team, surgical team, and the rest of the surgeons here who we all work with very collegially. And of course, I'd like to thank Introp for the funding needed to complete this clinical trial. So with that, I would like to thank the audience for participating and being interested enough to in this topic. I'd like to thank my family. Here are depicted my three children who make life very interesting. They're now 6, 4, and 2. And then, of course, Buckeye Pride and the Columbus crew. So with that, thank you, and I'm happy to take any questions.
We'll start our Q&A session now, and please submit your questions with the Q&A box. I can see some questions coming in. Dr. Biake, are there situations where adjuvant external beam radiation would be needed?
That's a great question, John. As I mentioned in the phase 3 clinical trial by the French team, which is the seminal trial that we have in the salvage setting, the pathologic information was not utilized to make this decision. And whereas the NRG and the EORTC, through Dr. Cooper and Dr. Bernier, they show that there are certain things that are very important in understanding when adjuvant radiation therapy is needed. So I do believe there is going to be times where we will need to do something in the adjuvant setting, but my hope is by having the opportunity to give a little bit of radiation before, perhaps in the A-grade ×2 arm, we're giving considerable radiation before in terms of an SBRT dose, that will be helpful. But this is a question that I think we need more data to answer. The fact that our preliminary work showed that over 60% of patients did not receive anything adjuvantly and still received about a 60% local control and overall survival at 1 year makes our team feel like this is an appropriate trial in this setting. But very good question.
Thank you, Dr. Biake. We have a couple questions about FLASH IORT. One is, what is the status of it? And what are your thoughts of using FLASH radiotherapy to be used in advanced and recurrent head and neck cancers?
This is a very exciting field, and Introp is doing an incredible job leading the way in the electron flash realm. We, as I don't know if folks in the panel are aware, we have an Introp flash machine. We're currently doing this in preclinical models in mice and zebrafish. Absolutely, we're thinking about this. We've put together, we're also very closely working with our veterinary school. We have one of the top veterinary schools in the country. And so we're working with them in a dog trial for predominantly sarcomas, but really a basket kind of care. So we have some protocols that are being, one that has been accepted, one that's been written that is going through the process. But currently we're in the preclinical model where we're really pushing to see the optimal settings in dose rate and dose in order to really see this flash effect so that we can move forward to higher vertebrates and also eventually into humans. In the salvage setting, for us, this could be amazing because if we can decrease the worry, in our clinical trial, we had about 10% grade 4 or higher, and in the French trial, it had close to 30%. And so the toxicity is something huge. If there's a way to reduce that toxicity and provide the local control, FLASH is incredibly promising in that realm. And we're absolutely excited, but in order to move forward, we have to be sound and the science has to be sound. And so that's what we're engaged on currently.
Thank you, Dr. Biake. Another question, how do you compare using electrons for IORT versus HDR brachytherapy? And which do you use more often?
So we have both. We use the electron more often. I've also trained with Dr. Lewis Harrison, who I'm one of his mentees, if you will. So I've done both. We've done predominantly electrons here, and I think both are good options. But the time with the new upgrades that Interop has provided, our surgeons are incredibly happy. We're often, and I don't want to jinx myself here, but we're often in and out of the room in as early as 15 to 20 minutes. And that's huge for 10 to 15 hour cases, and so that's something to consider. But I think they're both great options.
Thank you. Another question. How long does it take to complete an IORT procedure? And is it cost effective compared with other types of radiotherapy that might be used adjuvantly?
So also a great question. So in terms of how long does it take, it can take as little as 15 to 20 minutes to as long as an hour. What we've seen recently, and it's also operator dependent, right? That's in OSU, it is I, the radiation oncologist, and Dr. Grusula and Dr. Gomez, the three of us, that do the predominant work here, who are discussing with our surgeons, are setting up the Buckwalter, the applicators, in order to treat appropriately. So it can be operator dependent, as you can imagine, but I would say anywhere from about 20 minutes to about an hour is usually what we allot. And since often in these cases, there's flaps and there's reconstructive components of things, our surgeons are incredibly happy with us in terms of our timing, because it helps with flap. And so we're also looking into our surgical data to see how IORT is affecting the flaps. And preliminarily, it's really not affecting them, and it's only in a positive way because of the timing and so forth and their viability. But and then the second part of the question, John, remind me, was cost effectiveness. So I would say that the cost effective for IORT, if we do head and neck, and I will defer to my billing team. It's the nice thing about being at a big tertiary center. You don't think about these things as much, but if you think about 4 to 5 weeks of external beam after versus 7 weeks of external beam after, or 6.5 in the salvage setting, or none, to be frank, you can see how quickly the IORT component of this is much more cost effective. And if we can get similar outcomes than a phase 3 trial, and obviously more work has to be done. We're only starting this process, but you can see the excitement there, not only from a patient quality of life standpoint and toxicity standpoint, but also from a financial standpoint.
Well, thank you, Dr. Biate, for all that great information you shared today. And thank you all for attending. If you have any additional questions for Dr. Biate or Interop, please email them to intraop@intraop.com. And I would definitely like to thank you all for attending, and thank you so much for your presentation today, Dr. Biate.
Many thanks, everybody. I appreciated being part of the team.